Nicely, please carry on.
Yes.
Start from number 1.
Thank you and good evening to everyone. Thank you, Dr. Partha, for giving me this opportunity. What I'm going to talk is cataract with mild non-proliferative diabetic retinopathy with no clinically significant macular edema. I like to stress that cataract comes first because of the variation in the blood sugar levels. Cataract comes first and then comes the retinopathy. So most of the patients with cataract will have non-proliferative diabetic retinopathy. Here is a case, a 55-year-old male came to us with complaint of decreased vision in left eye. Patient was a known diabetic for last 5 years. Vision in the right eye was 6.6 and that in the left eye was 6.12. IOP was 13 and 16 millimeter of mercury. Anterior segment showed nuclear sclerosis with posterior subcapsular cataract. You can see fundus, it's near normal fundus with few microaneurysms seen in the periphery. There is no clinically significant macular edema. So the obvious choice in this patient is you go ahead with the cataract surgery, and the preferred mode to do cataract surgery is MICS, that is phacoemulsification with IOL implantation. The important thing here is you should make a large rhexis, put a large optic IOL, because if you make a small rhexis, then you are not able to visualize the posterior segment due to phimosis of the rhexis. Patient recovered with 6.6 vision. After 3 weeks, patient started complaining of blur in vision. Now you say that you have done a very good surgery, patient has recovered with 6.6 vision. Why the patient has complaining of deteriorating vision? Vision, when he came for examination, his vision has deteriorated to 6.12 and he says, I'm not able to see clearly. We did a dilated fundus examination of this patient. You can see hyperpigmented cyst on the posterior pole, not much of macular edema. If you see this hyperpigmented cyst, then the clinical diagnosis comes to be a post-operative cystoid macular edema. The incidence of post-operative cystoid macular edema in a normal cataract surgery is 2%, but in diabetic, it's 6 to 8%. So if you are operating a diabetic patient, then keep in mind if patient comes with a decreased vision after 3 to 4 weeks, then look for cystoid macular edema. So we did a fluorescein angiography for this patient. You can see a flower petaloid pattern, and OCT is the investigation of the choice where you see cystic changes in the macula. Now I go for a discussion. I'll ask my panelists, what is the line of management? What is the role of prophylactic NSAID? Posterior subtenon injection is more effective, or should we go for intravitreal steroids like IVT or DEX implant? Can I ask Dr. Saurabh?
Yeah, AG, the discussants for these are Dr. Saurabh and Dr. Rajesh. Saurabh, can you please comment on this? No diabetic macular edema prior to surgery, cataract surgery. Patient recovered good vision. Now he has developed a cystoid macular edema, which can happen in any cataract surgery, but incidence in diabetics is fourfold. We should all remember. A lot of people talk about stepladder pattern and pre-op use of say bromphenic or NSAID drops and continue. So his question is about line of management now, 6.6 to 6.12.
I would definitely, since it's only 3 weeks post-op, I would definitely go ahead with only nepefenac only. Buy some time from the patient, explain to him. Definitely no talk about intravitreal steroids or any intravitreal injection as of this point. Tell the patient, give him more time, especially I'm talking from the cataract surgeon point of view. The cataract surgeon needs to explain to the patient this is nothing with the cataract surgery itself, and that this is going to take a long time to go away, and there's no hurry in jumping to injections to wait for at least 2 to 3 months. It will recover probably before that, but telling the patient that you have to wait for at least 3 months to come back to normal, I think is more important. And seeing only topical diclofenac, I think should work in these patients.
So Saurabh, for how long do you want to continue?
At least 6 weeks, at least.
So 6 weeks you don't want to see him?
No, I will keep seeing him every 2 weeks.
Okay. Dr. Rosha, any comment on this?
If the patient's prevalence of the surgery has macular edema, and I do use intravitreal injection to treat before, but if I don't know anything and I just go to surgery, and after the surgery we has this edema, I do start with drops, non-steroid and steroid drops for 1 month. And if it doesn't work, I'm thinking to go for injections, anti-VEGF. But at first, I start with drops too.
Yeah, I agreed, because this patient pre-operatively, he did not have any diabetic changes. OCT was normal, but this cystoid macular edema developed post-operatively, that too after 3 weeks. So I think all of us agree that because spontaneous resolution of cystoid macular edema is a rule in more than 89-90% of patients.
Can I add something, Lalit?
Yes, Giri, I'm coming to you.
Yeah.
Yeah, so I think NSAIDs have to be started in there. But visual criteria, you see, normally what I would do is, if the vision is say 612 or slightly less, I am a very early institution of posterior subtenon injection. You see, because if the vision is slightly more, he has put it on the edge, 612. So I will wait for some time. If it is, if it was 618 or 624, I would have straight away given PST. But if it is 6/12 or 6/9, I agree with Saurav that, couple of weeks of NSAIDs should. Yes, Giri, now you can comment.
I mean,
Yes.
no, I thought I'd just add 1 or 2 points. One is, Saurav, the thing is that as far as a cataract patient is concerned, he will be very apprehensive, because this is a surgical procedure where, he is expecting good results immediately after surgery, and any complications. So if we tell him 3 months and all, then, it really puts him off. So I think we have to, patient counseling is very important, and it should be done in a very, methodical way over a period of time, rather than, just tell him that you have this problem, don't worry, 3 months later. So number one. Number two is that I agree with Lalit. And I think since he has had moderate NPDR, I think the ETDRS map has to be seen whether he had any center sparing thickness, increase in thickness, because patients who have a center sparing increase in thickness, the foveal thickness may be normal, but so some of them, immediately after cataract surgery, it progresses to a center involving DME. So in case after 3 to 4 weeks of treatment with Nepafenac, there is no improvement at all, I may do a fluorescein angiography in this situation just to see whether there is, to confirm whether it is a cystoid edema, or whether it's a pseudophakic cystoid edema, or whether there is an element of a diabetic macular edema in this situation.
Agreed. You see, all of us agree that couple of weeks of NSAID drops, if no improvement, have low threshold for injection. Yes, Saurabh, you have a comment or?
Just one comment. I agree, for the cataract surgeons, no angiography initially, stick to OCT, angiography only at a later date, because Dr. Avnindra showed the angiography nicely for far better, but I don't think it's advocated 3 weeks post-op category, because again, that would put the patient off very much, having further investigation. So I agree with Dr. The way he did the case, but no FA initially, only at a later date.
Agreed. I was also coming to that FA should not have been, the main investigation initially. If it is about only documentation and other thing, otherwise FA generally is not required for the first diagnosis of CME. Yes.
I agree to it because first we go for a non-invasive investigation rather than go for invasive investigation. But to complete my case, I have put this fluorescein angiography.
So let's ask Dr. Avnindra Gupta, what did he do ultimately? Yes. Sir, go to your slides.
Sir, can I go to my slide presentation?
Yeah. Go to your slides. So what did you do? After, improving 6.6, then coming to 6.12 again. So I agree, Giri, that patient's apprehension, after having improved So, AG, what did you do? Come to directly to the point. What did you do?
Sir, if we see the management is stepwise management. First thing, we add NSAID to the line of treatment with steroids. And if it does not resolve, then I start IOPAR, SR or Diamox once a day.
No,
And
can we have the what did you do in this case, because it's a case file?
yeah, I waited for 15. I waited for, I added NSAID and added Diamox for
Mhm.
2 weeks, and still the patient vision didn't improve. So I gave a posterior subtenon injection, and after 3 weeks, 2 to 3 weeks, the edema resolved, and patient again got back 6/6 vision.
Okay. So I wanted comments from the panelists with regard to Diamox or acetazolamide being given in dosage of 500 milligram.
Once
Yes.
a day, sir. Once a day only.
Yeah. So can we have comments from say Dr. Pramod Dhande or Dr. Giri about the use of Diamox? Pramod? Yeah.
Diamox, I am really not very sure about whether how really effective it is. So yes, NSAID probably yes, I would give. But just coming back a little bit also, Dr. Giridhar says, because we know these eyes uh, are prone to have a edema, they are prone to have worsening of retinopathy, any inflammation in the eye and intervention in the eye. So counseling is very, very important to
Yeah.
start with.
Giri,
So, but
Diamox.
Diamox, I am not very keen. Probably as NSAID, I continue, but I just have a word again, and probably cataract people know more than me. Like 3 months or 4 months NSAID, probably particularly in FFNAC, have his own issues.
Yeah.
So I would choose maybe Ketorolac or other sort of things. If you're particularly looking for a long-term effect, it does help. And even it reports, it sometimes takes 6 to 12 months for edema to completely subside, which is, I'm talking about post-cataract surgery edema, not even DME, I'm not talking about here. So we have to be aware of that. So it's a long-term treatment.
Yeah.
Keep on following, keep on treating. Don't expect dramatic results in a 2-3 weeks.
Yeah.
Like, sir, I would like to make a comment, if you allow me, from a cataract point of view.
Yeah.
Lalit sir, now since we all do cataract surgery and we get this type of patients, so my two questions: would we give prophylactic NSAID like Nepafinac
I am coming to
post-operatively?
that. First, let the treatment finish. We'll come to prophylaxis.
Okay, and what about the size of the rexis?
Yeah.
Avnindra mentioned that you should have a large rexis. We all cataract surgeons, we make a 5.5 to 6 millimeter rexis. That is a large rexis itself. So what do you mean by large rexis in a diabetic patient?
Yes, Amit, this question will continue for, in surgery when the patient comes for surgery also, and lasers also. Padmaja, about Diamox, are you a user of Diamox in such situations or not?
No. Diamox, I think we have to stick with the NSAID use only.
Yeah.
Like a stepwise ladder pattern, and also seeing in the visual acuity also taking into account in a stepwise algorithm, and also systemic control as well.
Yeah. That Rosha, what is your choice of NSAID? Is it Bromfenac or Nepafenac?
I prefer Nepafamac. I have good results with Nepafamac, but both work well if you persist. After 1 month, if you have some improvement, I think it's good to persist for 3 months. But if after 1 month, 1 month and a half, have nothing, sometimes I think to switch for different drug. I mean, to inject, thinking about the macular edema caused by the diabetic. But the Diamox, I don't use. I don't think the physiopathology is going to help a lot in this kind of macular edema.
Okay, we'll move on. We will move on to the second case. And before we move on, AG, any comment about Amit Porwal's query? I think he mentioned that we have to have a large rexis. You see, all posterior segment surgeons, suppose the case requires a laser or suppose the case requires surgery, a large rexis is always beneficial. Any comment, AG, you can say?
Yes, sir. I'll suggest that the rexis should be somewhere around 5.5 millimeter to 6 millimeter, because if you have an phimosis of the rexis, what I showed in this case, most likely if you have to do any kind of posterior segment intervention like laser or surgery, then we usually cut this fibromost capsule with YAG laser. That tends to enlarge the capsular axis, and our viewing becomes better for the posterior segment.
Okay, I think we move on to from mild NPDR now to a patient who has moderate NPDR along with CSME. And we have